Thanks very much to the committee for inviting us to speak about a fantastic symposium. Also, I'd just like to formally thank James Isbister. It's 50 years since he qualified in this field, and he really is one of the godfathers of patient blood management, and it's great that you're here, James, so thanks very much. So I'm going to give a bit of a different view on the world, as is a Glaswegian modus operandi. Really talking about, from the cardiac surgical field, is blood killing or saving our patients, or in fact both? Just to say, myself and James are on this national collaborative for optimising patient blood management, so I don't think it's a huge conflict, but just to mention it. Good to see Anthony's very sobering slides of the bleeding in conflict situations, and there's other conflict situations with cardiac surgeons we face every day. But it can be fairly difficult. Maybe when someone's shot, it's pretty easy to understand where the bleeding's coming from, but sometimes with a cardiac surgeon it's slightly less easy. But once you've seen enough of it, you realise that blood that's going up the way is normally a hole, and blood that's going down the way is normally coagulopathic. There's variations around the theme, but the cardiac surgical patient, I guess I'm justifying why we're talking about this, the cardiac surgical patient profile is different from perhaps the other patients that we're talking on, and it's one of the very large areas of blood use across Australasia, and there's always a multidisciplinary team or completely undisciplinary team working in this field, and which can make it slightly difficult. I guess cardiac surgeons could be associated with Oscar Wilde, who once said, "Moderation is a fatal thing. Nothing succeeds like excess." And it used to be very much seen by the cardiac surgeons, and really very frequently, and we'll still hear cardiac surgeons or their registrars saying, the number is 10, the number is 10, the number is 10. The more blood you gave, the better. And it's really taken us a little bit of time to get the conversation going, to speak the same languages between the anaesthetists, the intensivists, the cardiac surgeons, etc. More isn't always better, in fact. I guess looking at the papers in the last couple of days, is blood the new Kevin Rudd? It was a lifesaver, and it's now turned to a bastard. It's now the root of all evil, and in fact, does it have a role at all in medicine? Like Kevin Rudd doesn't look like he's got a role in politics. I stole this slide from James, but it's a fantastic slide. 1949, here we are, 2013, discussing this, whereas in 1949, this chap got it completely right, and we still haven't really got anything. This was really before the advent of cardiac surgery with Walt Lillehay and cardiopulmonary bypass. So even before cardiac surgery, we were realising the relative risks of blood, and we haven't solved that by today. I think we've got to rethink our use of blood. I was at the Asia Pacific ELSO Saturday, Sunday in Beijing, where Bob Bartlett, the father of partial liquid ventilation and one of the main men in ECMO, we were in the same session, and I said, you know, to a young pup, what is someone like you that spent 40 or 50 years in this field, what do you think the key aspects we've got to look for in high-end cardiothoracic care? And he said, we've got to understand blood, but I tell you the number is 15 because that is the number God gave us, and that's where we should be aiming at. So, but I questioned him and said, I agree the number is 15 that God gave you, but the creatinine God gave you is 120. When it goes to 180, do you transplant the kidney? Well, you're being facetious. Well, no, because if the number goes from 15 to 8, does that mean you need a transplant of blood? And as James beautifully described, this is a liquid organ transplant with a huge surface area and long-term implications. So we started getting interested in the cardiac surgery blood question because of looking at the variability of different institutions and the amount of blood that were given in different units. And we've looked at Jehovah's Witnesses and shown good outcomes as well in different units, really before the term patient blood management took off. Huge variability, between 8 and 80% of patients were transfused blood. And there's really very little evidence to say what we should be transfusing, what level we should be transfusing, what kind of factors we should be transfusing. There was some data suggesting when we started looking at this in 2005 that there was significant risk associated with it. So we just published this last year. We did a short and long-term follow-up of red cells and factors and platelets and followed it up for 5 years in the National Death Index. And essentially it's prospectively collected data. We tied it up with the National Death Index, looking at in-hospital mortality, secondary standard outcomes, and looking at anemia that's pretty high levels by today's standard, but was standard there. Not go through it too long in terms of time, but we had a large number of patients. We had about 50% of patients transfused, a gratifyingly low all-comers mortality at Prince Charles, where it's the largest cardiac hospital in Australia, 1.7% all-comers from cardiac surgery. But if you're transfused, your mortality was 3.6. versus 0.3 non-transfused at 30 days with a very strong statistically significant result. Again, going from the 30-day mortality to the 1-year mortality, if you're transfused 7.3 versus 3.9, right out to 5 years, 16 versus the 7. And really at this length of time, you're starting to think of the engraftment of lymphocytes and long-term changes that really you can't change by physiological things that are happening around the time of operation. And it's a fairly bold statement we finished the ATS paper with, but even after correction as much as we could for comorbidities, transfusion was still associated with a 66% change in mortality, and that's the survival aspect with red cells, non-red cells, and any transfusion. Non-red cells are platelets and clotting factors. So again, the question is anemia association or causation, what's going on immunologically, what's going on in infection, and what's going on from a dysoxia. So we're really stuck with this to transfuse or not transfuse. This is the question, and we need more evidence. And we've gone through some of the great evidence the guys have gathered for the guidelines, but I think cardiac surgery is still relatively underrepresented there, and that's why we started our little group. Sometimes we'll just see if this works. Got some
This
sound.
man right here is my great-grandfather. He was the first cat herder in our family.
This is what it's like to gather consensus.
Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, you know?
You see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
So I think that is in a way what we do, trying to gather consensus between intensive care, cardiac surgery and anaesthesia. That's what it feels like on a daily basis for ourselves. So we've talked a little bit about the lack of randomized controlled trials, and the TRACK study tried to do a randomized controlled trial published in JAMA, and it looked initially at 1,700 patients, but really if you look down to the bottom of the slide, by the time you've got all your exclusion categories, you're onto relatively low numbers, 253 each, and as Craig says, they're looking at higher numbers with it. Relatively well represented cardiac surgical cohort, looking at liberal strategy versus restrictive strategy, looking at the difference in the mean hemoglobin, so they achieved differences there. And this is looking at the probability of mortality, Kaplan-Meier, in terms of no units, 1, 2, 3, 4, 5, 6. The interesting thing that I've lost in the line here, I think someone was talking about tissue oxygenation, despite, they looked at also lactate levels as well. So despite the transfusion, the patients that were transfused, their lactate levels didn't change at all statistically significant. So that calls into question, we'll go on to that when we're talking about mechanism. How well does the transfused blood actually carry the oxygen? And that's clearly what we're trying to achieve. Again, harking back to what a couple of the previous speakers talked about, is really trying to dissect what's the effect of anemia, what's the effect of transfusion, and what about the effect of bleeding, because these things are clearly interdigitated, and this is just published in the annals in the last couple of weeks, trying to elucidate on a retrospective study the effect of the different 2 or 3 things. And I think this was Eugene Blackstone's work. So really what they've looked at is the effect of no preoperative anemia versus preoperative anemia and the operative mortality. So if you're anemic, every time before you go to theatre, you're going to have a worse outcome. It's like Anthony said, do small things well. Sure, the crashing, burn left mainstem infarct that's happening in front of your eyes, nothing you can do about it. But if these are elective cases going to theatre, there is no excuse that these patients should be going to theatre in an anemic state, because at each category, whether the massive bleeding, no, red cells, no, massive bleeding, yes, red cells, no, massive bleeding, no, red cells, yes, massive bleeding, yes, red cells, yes. Each category, the anemia, and we can correct that. In terms of the transfusion, again, if you've got a massive bleeding and you require more blood, you will have an increased mortality. Adjusting for confounders, same story, really. Again, which of the 3 evils do we pick? their exposure to red cell, transfusion, anemia, or both. Again, this is pre-published, I got on the web. A 9,000 patient cohort with cardiopulmonary bypass, 8,000 roughly got no blood, and 1,200 got blood. And they looked at what they called double exposure, single exposure, or no exposure. And results, not surprisingly, show that if you have exposure to anemia and transfusion, your outcome is worse in morbidity and mortality, length of stay, and cost. If you have a single exposure, either anemia or transfusion, it's worse. And if you have none of the above, again, your mortality is at its best. We can fix this, and whilst it's not an RCT, they've managed to try and tease this apart as much as possible. And this is a little bit difficult to see, but this is looking at EGFRs, length of ventilation hours, et cetera. So all the standard things that you'd imagine: troponin scores, length of stay post-operative, ventilatory support, GFR, et cetera. Looking at long-term follow-up as well, this paper looked at the long-term follow-up out to 5 years. So the no red cells in the top, red cells down below, and those that were anemic to kick off with. So one of the suggestions we've got, and we're going to trademark this one, it's the Pooh Bear phenomenon. You may not have read about it in the textbooks yet, but Pooh Bear got stuck in a hole because he wasn't quite morphologically adapted, or he was too fat to come out of the hole, and he squeezed into the hole but couldn't quite squeeze out of the hole, and there's a blockage behind him. And I think this is perhaps when we're talking about whose blood is safe. Is it your own blood or is it the donor's blood? Because our red cells are about 7 micrometers and they go down a 2 or a 1.5 micrometer capillary, microcirculatory capillary, and get through out the other end and then reform the shape. But with the old red cells that you saw the nice micrographs from James's talk, that this red cell is much less morphologically adaptable, can't get through there, and this area becomes relatively ischemic. In terms of other things, we'll not go into this too much, but in terms of the efficacy of FFP, this has also been questioned substantially, and there's some data to suggest that the time it takes to correct your coagulopathy with FFP is actually incredibly long because of the dilutional effect, and I think in cardiac surgery we'll be looking much more at factors, and particularly in National Collaborative, that's what we're looking at. So we can fix simple things. We should be able to do the simple things well. And again, a very recent paper, I've really stuck with a recent paper, I've assumed most people know the other literature. Is blood conservation a learnable skill? It's a pretty, people say, well, it works in their hospital, it would never work in our place. But this is once they've put in a patient blood management program across in one centre, and they've just shown red cell use, FFP, platelets, and year by year by year, it is a learnable skill. And we can see from the other studies that the less we use, the better. As Aristotle said, we are what we repeatedly do. Excellence then is not an act, but a habit, and what we need to do is form the habit of optimizing patient blood management to the things that we can do. So how does this translate into outcome? Again, Blackstone's all over this one. It was a 17-centre, 14,000 pre- and post-guidelines, so implementation of patient blood management. They showed post-guidelines, less ventilation, less dialysis, less infection, 47% reduction in odds of death. If you were transfused, your complications got worse, and as is very important today, the Health Economist substantially cheaper by several $100s. So their conclusion on this was that limiting intraoperative and postoperative blood transfusion decreases adverse post-operative events, reduced costs, blood conservation, and bolstered by collaborative and guideline development, which is exactly what the team here have done. This just goes through some of the other data. So what about the patients? People say, well, this data, our patients are different. This is cardiac surgeons like to say that. Our patients are different. We're seeing more acutely unwell patients. The cardiac, what about the ischemic patient? They must do it. Well, that's actually not true. And this is an older paper from JAMA where they took 3 or 4 of the big lysis studies. And again, it's retrospective, and they've done propensity scoring and all the clever stuff, but it's still retrospective, so bear that in mind. But even with that, if you start to look at 24,000 patients, and after adjustment as much as they could, blood transfusion is the black line, and no transfusion is the lower line in patients who are having an infarct. So when people say, well, we need to transfuse them because they're having an infarct or they've got acute ischemia, remember the slide that shows transfusion doesn't change your lactate, and remember this slide suggesting, for at least an association with transfusion and increasing mortality in the acutely ischemic patient. Again, only 6 months ago, this paper, it's been criticised, including by Paul Herbert. Chatterjee looked at association of blood transfusion with increased mortality in myocardial infarctions. So he took a whole pile of papers, looked down and included 10 studies into this study. Again, showed the same sort of idea that favours well against transfusion in someone. So someone who's got hemoglobin of 9 but is infarcting, there is no reason to transfuse that person, I would suggest. Again, not only does mortality go down, but also you increase the risk of subsequent infarction, and it may be related to our Pooh Bear phenomenon in the microcirculation. Other companies have gone and said, other groups have gone and said, well, that's fine, but renal failure, ventilation, that's all the sort of things that happen to patients that need cabbages. So this group did quite a nice study. I thought it wasn't the biggest study, but they looked at patients who needed cardiac surgery but had normal coronary arteries, so therefore normal vascular or normal-ish vasculature around their other organs. Looked at aortic valve and looked at their transfusion of platelets, plasma, and FFP. And again, they didn't show a detrimental effect with red cell, but what they did show was a significant effect, a detrimental effect of FFP transfusion in this patient population. So one of the things we're interested in is looking at the mechanism. It's fantastic to see the guidelines, but Craig was very honest in saying, we think this is it, we hope this is it. So I think we do need more mechanism. It's not to say that's everything. The randomized control trial is fantastic, but as was discussed earlier on about the FEAST study, people sort of say, well, is it real, is it not real? So we need to add some mechanism to that, and we do a lot of work in our animal lab looking at transfusion of old and red cells in there. We think the sheep's a good model. We talked about the potential of a pig earlier on, myself and James, but really the sheep red cell stays about the same as the human red cell. The CEOC paper and Proceedings of the National Academy of Science really showed the huge genetic dissimilarity between rodents and humans, so they're out of the question, and we can look after our sheep in our animal ICU. What's important, though, before you start using a model such as sheep is you need to say, well, the sheep red cell, the sheep hematopoietic system is relatively similar to humans. So we started looking at a comprehensive bovine transfusion model assisted by the Red Cross Blood Service and collected the blood and packaged it and did all the normal things that the Red Cross Blood Service do. So it's exactly processed the same way. And we transfused it. We looked at compatibility and incompatibility. We've just had the paper accepted this month in Vox Sanguinis, really showing that there are substantial similarities and that when we go back and look at mechanism to try and help the trialists to try and say, look, maybe this is an RCT you should look at next, or this is an outcome perhaps you should look at. We think that the sheep model we've created is going to definitely assist there. James also alluded to the fact of Trolley, and Trolley is one of the major problems. Rather than just transfusing the wrong blood completely, it's the major cause of blood in the SHOT study. We believe it's a two-event mechanism, and we think also in sepsis it's a two-event mechanism. We're investigating that at the moment. We see the hypoxemia and pulmonary edema of Trolley. We've created the first large animal model of Trolley, looking at a first hit of lipopolysaccharide and then a second hit of a transfusion, either old or new product. I'll just zip through this because it's not really what I was asked to talk about, but I'm going to talk about it anyway. Really to show that, and this is John Paul Tung's work from our group, to show that aged, so if you give lipopolysaccharide or saline to sheep, they don't get Trolley, but if you give aged product to sheep, they start developing Trolley. So it's really putting an idea behind the concerns of the age of blood. And you see these are the sort of pictures from healthy lung. This is aged blood with lipopolysaccharide. The hypoxemia you see develop consistent with stored blood, very, very statistically significant post-transfusion. Pulmonary arterial hypertension, also consistent with it, as John Paul, some of the work he's done there. And then what we've gone on to is not just to look at the tissue oxygenation, but also the ability to metabolize with that oxygen. The red cell might go past your organ, but if your organ can't actually use it and metabolize it, then it's really not doing much use. So this is really, we're replicating the FEAST study with Kath Maitland, who's working with our group, to actually put some mechanism behind why is it that transfusion of old or new red cells or non-red cells is good, bad, or indifferent. And we'll just zip through this. But essentially, what we've shown is the global hemodynamics is actually not that useful a sign, but tissue oxygenation, and this is some preliminary data, but what we're actually seeing, this is looking at a tissue oxygen probe in the renal parenchyma, showing that red cells, new red cells work quite nicely. Saline isn't that bad, but old red cells really is worse than saline, perhaps, at giving you tissue oxygenation. So we need to worry about this, and we'll moving on to this model soon. Again, looking at the myocardium and sepsis, so we've got trauma models and we've then got sepsis models, because inflammation is not the same beast, and we're looking at how the tissue actually metabolizes and uses with this oxygen. And what we see in the septic modeling is that the glucose in the myocardium drops off dramatically. There are cutbacks in research in our hospitals everywhere, but so we're using 2 sheep at the one time to minimize costs. In terms of the age of blood, there's a lot of work going on here. This is looking at a human and sheep model. Hemolysis follows the same path. A lot of the biochemical factors follow the same path in pH. It really is important that we understand that. Moving on from there, we understand that there's issues there, but also I think one thing that we need to remember is we can't treat the cardiac surgical patient blindly.
Cool, like cricket?
Yeah, down at the Blind Institute.
Oh, how do you know when the ball's coming?
Well, the ball's got a metallic core with a couple of bells in it, so you can hear it coming.
Oh, really? Bells?
Yeah.
Have you got your gear here?
Yeah, it's just down there.
Oh, wow, that's amazing. That's really loud. You should have a bowl.
Oh, come on, I'll grab my bat. All right, don't hold back. I'm pretty good.
All right, then.
So I think treating a patient in the cardiac surgical area in a blind way could also be as potentially as deleterious as if you're a cat. So what we've started doing, and we won't go on too much to talk about this, but we're talking about point of care, and there's doing the simple things well, but also giving us something at the bedside that we can get a result, with due respect to James and his cardiology colleagues, that we can get a result within 10 or 15 minutes to decide what we're going to do. This is Klaus Gerlinger's slide, but we've been successful getting a grant, and Bronwyn Pierce has presented some of our outstanding work, that even in a year at Prince Charles, we've dramatically reduced the blood use, the cost, and probably associated with less sternal infections and a trend towards less morbidity as well. So I think we do need something to help us as well around there. So to finish up, Madam and Mr. Chair, there is a physiological and financial cost with blood. There is benefit, there is harm, and it's really about finding that sweet stock. We need to understand the mechanism, and we need a real-time guide to help us. It is a team game. You're never going to get past without seeing one of those slides in my talks. It is a team game. Everyone's got their position. There's no point of having 11 strikers and no goalkeeper. So we all have our part to play in doing the simple things well. Last video of the talk, this is in honour of James Isbister. I guess these things were all thought of as very bizarre many years ago, and this is a Saskatchewan music festival. And I would put it to you, Madam Chair, that this is James Isbister, a year or two ago, who led out the field of patient blood management. May have been seen as a particularly odd fellow when he started it, because hemoglobin of 10 was fine. No one was really that keen to follow. And then perhaps that's Craig French, having a dance with him along the side. Again, the rest of the medical population was probably not too keen to follow. They stood out as a sore thumb in the festival. But bit by bit, what we're seeing is that the evidence is starting to gather. And what we need to do is be innovators like people at James, not the laggards, listen to the evidence, look for more evidence, adopt the guidelines that the NBA has so beautifully put out, and look for more evidence so that bit by bit, sadly I think that might be me, I'll just say that before Sandy does, and bit by bit the community will start to follow and will hopefully achieve better outcome from our patients as the more people start to gather. I'll let that play whilst we get some questions. Thanks.